Dr. Melaku, I'm Gracia, and Dr. Matty, the website is not good, so you can start. Yes.
Okay, thank you. Thank you, everyone. Good afternoon, everyone. Thank you for making the time for this talk on vitamin D. I am Melaku. I'm an internist and endocrinologist at Rambasa Specialized Hospital and an assistant professor of medicine in Addis Ababa University. I'm grateful to Wondfo for their contribution in improving diagnostic quality in Ethiopia. In my clinical practice, reliable lab partners like Wondfo matter a lot for vitamin D and all other hormone testing. And thank you for that. So we'll be discussing about the updates. So who should be tested, who should be supplemented, and why we should do that. Today, this is, I don't have any financial disclosure. The only objective I have today is just to contribute in translating the newest evidence, particularly the updated Endocrine Society guideline for everyday clinical decision. These are the agenda for the talk. We will review the relevance of vitamin D in health and disease. We will also highlight the burden and clinical feature of vitamin D deficiency. We will also talk in detail how to make a diagnosis of vitamin D deficiency and emphasize the role of reliable testing in vitamin D diagnostics. We will also discuss about how to replete vitamin D, and at last we will see public health approaches in preventing vitamin D deficiency. So for quick polls, who does routinely order vitamin D test for general checkup? You can show up your hands on the Zoom for 30 seconds. So I could see one guy raised his hand. Okay, so this talk is going to be helpful whether you routinely order vitamin D test for general checkup or not. So the sunshine hormone, the vitamin D, is not a vitamin. It's a hormone. It's a fat-soluble steroid hormone. And you know that the research around vitamin D is ever increasing, especially the bone versus extraskeletal effects on immune system, metabolic, cardiovascular, cancer, and pregnancy outcome is increasing. But the controversy, especially when the association of low vitamin D with diseases versus a causal effect is not settled yet. The threshold level, what level of vitamin D defines sufficient, insufficient, or deficient, is still controversial, and I hope this lecture will clear some of that controversy. So vitamin D is not is a term that can be used for all 6 steroid hormones, from cholecalciferol, which is derived from the cholesterol endogenously in the skin or from animal sources. It's hydroxylated into calcidiol, which the liver, and later hydroxylized again in the kidney. This is the active form, or it could be the plant-derived ergocalciferol, which is the same way, like that of the endogenously produced or animal source vitamin D, the same way undergoes hydroxylation in the liver to the diol form, and again hydroxylated in the kidney, activated in the last step to calcitriol form. So all these 6 hormones go by the name vitamin D. So when we say vitamin D, it does not specify which of these actually. And mind you, whether it's plant-derived or animal-derived or produced endogenously, they are bioequivalent. So they work the same way, they are processed the same way. So to review the physiology and metabolism of vitamin D, so the skin produces this hormone from its precursor, cholesterol precursor, 7-dehydrocholesterol. When the UVB light strikes the skin, there will be chemical change. This is not enzymatically mediated. So this is a chemical mediation change to cholecalciferol, or the animal diets can also give you some sorts of D3, or supplements could be there, or the plant source give us the ergocalciferol. Both D2 and D3 undergoes liver hydroxylation, 25 hydroxylation, the same way, and later in the kidney, that's converted to calcitriol. So this step, the kidney hydroxylation step, is highly regulated. PTH activates this process, whereas FGF23 and phosphorus and calcitriol itself and high calcium inhibits this process. And when we don't need calcitriol, it will be inactivated to the 24 hydroxylated forms. So this is one way of regulation, inactivating the vitamin D. So to see on the photobiogenesis or the cutaneous vitamin D production, when the UVB strikes the skin, there will be photochemical cleavage of the 7-dehydrocholesterol into vitamin D3, which enters the dermal circulation and later carried with vitamin D binding protein into the liver. And the more skin is exposed, the more vitamin D production will be there. This is a very efficient process, by the way. Even brief exposure of direct sunlight exposure will produce a daily dose of vitamin D supplement equivalent. So generally about 15 to 30 minutes of quality direct sunlight exposure each day, or most of the days, will be enough to meet our bodily vitamin D requirement. For darker skin, for older age, or for individuals with obesity, it takes longer. So they need to expose a little bit longer, 30 minutes plus, most of the days. There are some factors that affect the cutaneous production of vitamin D. So if the UV penetration is blocked with melanin, with sunblocks, or excessive clothing, that affects the cutaneous vitamin D production. Also, the sun exposure also affects, where you are, the time of the year and time of the day matters. The optimal angle of solar radiation that optimize vitamin D production is somehow 45 to 90 degrees. So the simple rule of thumb is if your shadow is longer than yourself, you are not probably making a good vitamin D. That means the angle is less than 45 degrees. And it decreases with aging for lots of reasons. The second source is dietary sources. So unfortunately, vitamin D is found in very small quantities in very few food items naturally. So the best one is the cod liver, the fish oil. So 15 ml of fish oil is equivalent to over 1,000 units of vitamin D. The others are really small amounts. So we depend on fortification rather than natural source of vitamin D sources. So if you take for instance, one egg, which is found in the yolk, it's a very tiny, 25 units per day from one egg yolk. From fortified milk, a standard cup, it can give you 100 units of vitamin D. But generally, the sun is the base source of vitamin D. The vitamin D is naturally very small in very few foods. So after you synthesize it in the skin or ingest it, it undergoes hydroxylation in the liver. It's a mitochondrial and microsomal enzyme. So this is the 25 hydroxylase is the enzyme. This is not PTH dependent. And the product is 25 hydroxy vitamin D. So this is the major circulating form and the major storage form. This is what we measure in the lab. And the half-life is long, 2 to 3 weeks. But it's not potent to bind the vitamin. So the potency is close to 1% of that of the calcitriol. What's better than calcitriol, it's very long acting and the concentration is high. So calcitriol is very potent, but very short half-life and a very small quantity in the circulation. So we don't measure calcitriol in the blood. We measure 25 OHD. So it then undergoes renal hydroxylation. The major site is proximal convoluted tubules, and the enzyme is 1-alpha hydroxylase. So it produces calcitriol or 125 vitamin D. So the half-life is very short, and this is the active form that binds to the nuclear receptors in target tissues, mainly in the intestine, and it regulates gene expression. So it's related to the steroid receptor. So this is a highly regulated process. PTH induces renal hydroxylation, and very low phosphorus also induces this enzyme, whereas vitamin D itself, calcium itself, FGF23 and phosphatemia inhibits this process. So this is a highly regulated process. So how does it works is like any other hormone. It acts through the vitamin, through its receptor, which is a vitamin D receptor, VDR. So this is a nuclear receptor, and it's ubiquitously expressed in many tissues. So you can guess that the function, the physiologic function role of vitamin D is many varied. So from the blood, it binds to the vitamin D binding protein. Then it's a lipophilic hormone, so it diffuses across the cell membrane, and it goes to the nucleus, binding the vitamin D receptor, the nucleus, and this affects gene transcription and protein production. So the most important biological action is to promote intestinal calcium absorption. This is the most confirmed way of vitamin D action, but it has also other effects, like it stimulates intestinal phosphate absorption, it directly suppresses PTH release from the parathyroid, it regulates osteoblast function, it also allows PTH-induced osteoclast activation and resorption, it also helps in calcium retention at the kidney and many other extra skeletal function. So the major site organs are the intestine, the bone, and the kidney, plus the parathyroid. So in the intestine, it's a PTH-independent calcium and phosphorus absorption. In the kidneys, it's a PTH-dependent renal tubular reabsorption of calcium and phosphorus. In the bone, it promotes the bone formation and also PTH mediated osteoclastic bone resorption. In the parathyroid, it inhibits the parathyroid PTH secretion. So this is kind of regulatory to suppress PTH secretion when there's calcium is high. It has also effect on the extra intestinal tissues, I mean extra skeletal tissues. So you can see that the effect of vitamin D is pleiotropic, is a lot, and it's incriminated in many health and disease states that I'll show you later again. So when we come to vitamin D deficiency, it could be subclinical or overt vitamin D deficiency. Overt is when it's symptomatic with hypocalcemia or hypophosphatemia, causing bone problem, rickets in children, or osteomalacia, but we are not seeing this a lot now because of fortification and supplementation. So overt vitamin D deficiency is rare. So we are dealing with subclinical vitamin D deficiency. This is a major public health problem and associated with osteoporosis, falls, fracture risk, and many other extra skeletal disease association is there. But the causal effect is not confirmed yet. If you see the burden of subclinical vitamin D deficiency, this is a global pandemic. So the global prevalence, a recent systematic review of over 300 high quality studies from 81 countries shows that, the severe vitamin deficiency less than 12 nanogram per ml was close to 50%, and those less than 20, mild to moderate deficiency less than 20 was close to 50% of the world population affected. And if you use 30 nanogram per ml as cutoff to define vitamin D, this will be more than 3/4 of the world population. So some of the risk factors identified in this systematic review was age, dark-skinned population, excessive clothing, and limited sunlight time as you go away from far away from the tropics. The US data is a little bit better. So vitamin D deficiency defined as less than 12 nanogram per ml is about 5%, and inadequacy, which is 12 to 20, is about 1 in 5. So this shows that this is a global problem that we are dealing with. In Ethiopia, despite being a country of 30 months of sunshine, there are some studies showing vitamin D deficiency is highly prevalent in school-age children, for instance. So this is an important age group because this is when the bone mass accrues. So vitamin D deficiency defined as less than 20 nanogram per ml was close to 50%. It was more common in urban schools than rural schools, and it was more common in some of the cultures that use more clothing, more covering. And those kids overweight and obese were also at higher risk of vitamin D deficiency. They also did this assessment in pregnant women. The same, close to half of them were vitamin D deficient, defined using 20 as a cutoff. And there was a recent systematic review as well. So the pooled prevalence was shockingly close to 2/3 of the Ethiopians affected by the vitamin D deficiency. And this review also noted that vitamin D fortification is inadequate or non-existent in Ethiopia. So this shows that having an abundant sunlight is not a guarantee for vitamin D adequacy. So these are the causes of vitamin D deficiency or resistance. So the commonest cause globally is decreased skin synthesis because of inadequate sun exposure. Or sometimes if you are using too much of protective clothing or sunscreen, that's also contributes. Dietary intake also contributes. We said that adequate sunlight is not a guarantee. So diet absorption also contributes to be a dietary problem. If there's no adequate food fortification, that's going to be a problem. Some people could have malabsorption after surgery from IBD or celiac disease. And nowadays we see gastric bypass for weight loss surgery that can cause vitamin deficiency as well, or pancreatic insufficiency from alcohol or any other cause is also incriminated. But sometimes the intake and skin production is okay, but if the liver does not hydroxylate it, it's not going to work. So in patients with liver disease like cirrhosis, INHUs, or genetic mutation of the enzyme can also give you vitamin D deficiency. Obesity is also incriminated in vitamin D deficiency because it's said to affect liver hydroxylation of the provitamin D. So sometimes you can take enough, but if there is increased catabolism of vitamin D into inactive metabolites, that also contributes to deficiency. This is common in patients with epilepsy taking anti-epileptic medication. Rifampicin and barbiturates also contribute. Sometimes if you are losing the vitamin D binding protein in the kidney in case of nephrotic syndrome, that can also lead to vitamin D deficiency. The other is defective renal hydroxylation because of kidney failure or failure of the regulatory system like hypoparathyroidism. Sometimes genetic abnormalities add in vitamin D dependent rickets type 1. These are some of the causes of defective hydroxylation. Sometimes the vitamin D is there, but it's not working. This is the vitamin D resistance. This is called the vitamin D dependent rickets type 2. And these kind of patients require calcium and phosphorus infusion because any type of vitamin D you are giving, it's not going to work. So why is that vitamin D status is low even when abundant sun exposure is there? So we know that lack of sun exposure is the main cause of this pandemic, low vitamin D status worldwide. But even in tropics, when sunlight exposure is adequate, or individuals who have seemingly adequate UV exposure, they might develop a vitamin D deficiency. So this is because of genetic changes and variable responsiveness to UVB radiation. To show you a data on this, so this Hawaii study studies 93 adults who has adequate sun exposure over 3 hours per day and most of the days of the week. And this was not just self-reported. This was ascertained, confirmed by sun exposure index using reflectance calorimetry. And these were young people and not obese people. And you could see that their hour of sun exposure is adequate. But when you come to the vitamin D status, 51% of them had vitamin D level less than 30, using 30 as a cutoff to define deficiency. So the mean value was about 31, and the highest was about 62. So this shows you that this graph shows that having adequate sun exposure is not a guarantee for adequate vitamin D status. So what happens when there is vitamin D deficiency is it leads to impaired intestinal calcium absorption. This results in lowish calcium, lower calcium from the baseline value of that individual. This results in secondary hyperparathyroidism. The increased PTH aims to maintain eukalcemia. So this will result in, PTH resorbs the bone, and this will demineralize the bone over a long period of time. And some of the other compensatory mechanisms is increased renal 1-alpha hydroxylase activity. The calcium excretion will be low, and because of the PTH, there will be phosphaturia and hypophosphatemia. So hypocalcemia plus hypophosphatemia will result in osteomalacia in the long term. So these are the effects, both skeletal and extraskeletal effects of deficiency. So in the skeletal system, over a long period of time, there will be rickets in children or osteomalacia in adults. And if it's severe enough, it can cause frank hypocalcemia. But it also affects the immune system, the adipose tissue, the pancreas, the skeletal muscle. All this leads to cardiometabolic disease, including progression to type 2 diabetes. So what are the clinical features of hypovitaminosis D? Is the classic severe vitamin deficiency is rare, and this happens in very severe vitamin deficiency and long-standing deficiency. It can cause rickets or osteomalacia, and it can actually cause frank hypocalcemia with myopathy, difficulty walking, and bone pain or tenderness. But this is rare. What we deal with in the clinical setting is a subtle non-specific symptoms when there is mild to moderate vitamin D deficiency. So I'll show you why I use these numbers to define mild to moderate deficiency. So they will have non-specific symptoms like fatigue, myalgia, non-specific musculoskeletal pains and aches here and there. They could also have neuropsychiatric symptoms like depression, but largely they could be asymptomatic. It's associated with plethora of diseases, including diabetes, hypertension, cardiovascular disease, cancer, infection, and pregnancy outcome. But the cause effect is still debated, but we know that it's very low vitamin D associated with these diseases. So coming to diagnosis, how do you what are the diagnostic evaluations we do in vitamin D deficiency? So we said that the 25 OHD level is the most specific screening test to determine vitamin D status. This is the circulating form and the storage form of vitamin D. And it has long half-life, we said, as it binds to vitamin D binding protein. Most patients with mild to moderate deficiency, which is defined as 12-20 nanogram per ml, they do not require additional testing. But if you find severe deficiency, less than 12 nanogram per ml, they require further testing. You should check calcium, phosphorus, PTH, and LP as well. You should also do renal function tests, electrolyte, and sometimes celiac disease screening. If they have localized bone pain, you can do targeted radiologic imaging, but you don't have to do mineral bone density assessment or DEXA scan at this stage. Because if you find osteoporosis, it does not, vitamin D replacement actually can improve the BMD before you start anti-osteoporotic therapy. But for most patients, checking 25 OHD is enough. For severe cases, you can do more. So how do we define vitamin D sufficiency? So for skeletal health, this is there is a consensus that the optimal level of vitamin D for bone health is between 20 to 40. So this is the National Academy of Medicine definition. We know that vitamin D level less than 20 is suboptimal for bone health, but we don't know what's optimal for extraskeletal health. So these were some of the criteria or the strategies used to define optimal vitamin D level. One of the methods is at what level of vitamin D does maximal suppression of PTH happen. So this is one way of knowing the optimal level of vitamin D. The second is what is the adequate intestinal calcium absorption at certain vitamin D level. So this is the second way of ascertaining or defining optimal vitamin D level. The third is clinical endpoints. At what level does fracture increase? At what level does fall increase? And so on. So I'll show you each of these with evidences. So the amount of vitamin D that suppresses PTH, we said that vitamin D receptor is in the parathyroid gland, so it suppresses PTH secretion when calcium is adequate, right? So this study analyzed 445 patients above 65 years old. This is a calcium and vitamin D intervention study, STOP IT study. So the vitamin D concentration level necessary to maximally suppress PTH was about 27 to 30 level. So this is, you would say 27 is low, right? As most labs show, less than 30 is insufficient. But in this normal, healthy, elderly individuals, the vitamin D level that's important to suppress PTH was about 27.5 level. So this is one way of defining what's optimal vitamin D. The other is at what level of vitamin D is the intestinal calcium absorption optimal? So we know that intestinal calcium absorption depends on vitamin D. So if vitamin D is substantially reduced, we know that calcium won't be absorbed, right? And this reduction in intestinal calcium absorption happens really at a very low number, which is about 4 nanogram per ml, right? So if you have vitamin D of 10 or 8 or anything above 4, the intestinal calcium absorption is not actually significantly compromised. And this was ascertained by when it's less than 4, there will be increased PTH, increased LDP showing bone resorption, and urine hydroxyproline. This is also a bone resorption marker. So below this, it fails to maintain optimal calcium absorption despite the secondary hyperparathyroidism there. So this tells you that the optimal vitamin D level is really lower than what we expect. The third way of knowing the optimal vitamin D is by just looking at clinical outcome. This is what I'm interested at as a clinician, bone outcome. So fracture endpoints are probably the most proximate indicator to define optimal vitamin D level. And most clinical trials that studied bone outcome, fracture, fall, osteoporosis endpoints showed that a vitamin D level above 20 and up to 40 is optimal for bone health. So you don't have to treat and normalize a vitamin D level of 25 or so. So based on this, international guidelines are there to define what's vitamin D sufficiency, insufficiency, and deficiency. So the National Academy of Medicine, in the old days, it used to be called IOM. In 2010, it defines vitamin D sufficiency as any vitamin D level above 20 is normal or optimal. Vitamin D insufficiency was defined as vitamin D level between 10 and 20 nanogram per ml. Deficiency was defined as vitamin D less than 10. So these thresholds were based on bone outcomes, meaning hip fracture rate and bone resorption markers increased below 20, and they were optimal between 20 and 40. So this is convincing for me. As a clinician, I want to see clinical outcomes rather than lab biomarkers, right? The Endocrine Society in 2011 as well put definitions for sufficiency, insufficiency, and deficiency. So Endocrine Society used 30 to define sufficiency. Anywhere 30 to 100 is normal. 20 to 30 was defined as insufficiency, and less than 20 was defined as deficiency. So these thresholds were based on the biomarkers. This was not based on clinical endpoints, meaning they use calcium absorption levels and PTH to define those cutoff values. I showed you that the maximum level of PTH secretion with vitamin D happens around 27, right? So they use that study to define these thresholds. I personally lean towards the NAM 2010 thresholds because they use clinical endpoints to define the thresholds rather than biomarkers. For extraskeletal health, there is no consensus at what level low vitamin D contributes to disease, but we know from epidemiologic studies that vitamin D level below 20 nanogram per ml is shown to be associated with increased risk of cardiometabolic disease, cancer, infectious disease, including COVID-19, and autoimmune disease, including type 1 diabetes and many other autoimmune disease. But the causal link is not confirmed, has not been established yet. But we know that it could be many other confounders, and because this disease and vitamin deficiency is so common, it could be just an overlap. And also vitamin D supplementation is not effective in reducing the risk or prognosis of all of the diseases we mentioned. So it just tells me that it might not be, the deficiency could be just a finding, a common finding, because it's just common rather than a cause. So the optimal level of vitamin D for extraskeletal health is not established clearly. So because of this association with low vitamin D and multiple cardiovascular cancer infectious disease, there is a global trend towards increased vitamin D testing and supplementation. And in the US, if you compare what was the supplement rate in 2000 and 2014, there was over 18 times increased, right? So this is because of the evidence showing vitamin D deficiency is associated with many other diseases. However, the causal effect was not proved, and I said that supplementation is ineffective in reducing the risk or prognosis of any of these diseases. So universal screening or broad-based screening of the general population or during pregnancy was de-emphasized in the recent guidelines. So rather, guidelines focus on importance of testing, quality testing in selected high-risk groups. So what are the international perspectives on vitamin D testing? While there's a consensus that vitamin D matters for bone and extraskeletal health, there is less agreement and consensus on how widely to screen and how to define the thresholds that we saw. So in Canada and US, for instance, the guidelines recommended against routine testing in low-risk adults, and they focus on testing, quality testing in high-risk individuals. The most recent guideline, the Endocrine Society guideline in 2024, also suggests against routine testing in healthy populations, and it emphasized targeted supplementation and quality testing when indicated. So the takeaway from most of the international guidelines is it's moving away from universal population-based screening toward the selective testing and supplementation in high-risk individuals. So the Endocrine Society said last year that not to routinely measure vitamin D in low-risk adults, including general healthy adults, older population, or pregnant population. You don't have to routinely test, including obesity and having dark skin is not an indication to do vitamin D testing. The United States Preventive Task Force in 2021 also recommended against universal screening for vitamin D deficiency in the general population. It rather emphasizes the importance of vitamin D testing, quality vitamin D testing when indicated. It showed that the methods and the B2 laboratory differences, inconsistencies were common in US labs. So the UK also in the NICE guideline also recommended restricted testing to test only if someone has symptom of deficiency or is at high risk. It recommends against routine testing. It also puts forward indications to screen. So this is not an exhaustive list, but these are the common indications to do vitamin D. So in patients with calcium disorders, in patients with parathyroid disorders, in bone problems, including osteoporosis, patients who had malabsorption syndrome, including weight loss surgery, and disorders that affect the liver or the kidney, or patients, drugs that affect vitamin D metabolism, including glucocorticoids and anticonvulsants, and patients whom you think, the clinician thinks this is a vitamin D deficiency symptom, you should do testing. But you don't have to do vitamin D test routinely for everyone. The most important thing is when you decide to test, the reliability of the test matters. And one of the challenges in vitamin D testing is the assays is a major issue. So we know in research setting, the liquid chromatography and tandem mass spectroscopy is a standard, but the assays we used in the routine clinical setting has a major inconsistencies and variability. And we also don't have a population-specific difference range to say this is normal, this is abnormal. So when you decide to test, you should have a reliable and quality test there. So you tested a patient when indicated and the result came back. So how do we manage it? So if there is no indication to screen, don't screen, right? Don't screen routinely. So you can just advise the normal recommended vitamin D intake. Now for those above 70 years, 800 units per day is the daily requirement. For those less than 70 years, 600 units per day is enough. But if you have an indication to screen and you got a reliable vitamin D assay like that of Wondfo's, and if the test is, the result is less than 12 nanogram per ml, so this is severe vitamin D deficiency, you have to use mega dose of vitamin D for 2 months. For 1 to 8 weeks, you should give suprapharmacologic mega dose of vitamin D per week together with calcium supplement. And after the 8th week, you can give the lower dose 800 units per day. And you have to monitor if the vitamin D is repleted after 3 to 4 months of therapy, right? If the vitamin D level is between 12 to 20, you can supplement a lower dose on daily basis, right? You don't have to give the mega dose, weekly mega dose of vitamin D, and you have to monitor the response within 3 to 4 months. If the vitamin D level is above 20, you don't have to give therapy. You can advise to take the daily recommended values, or for some indications, you can give low dose supplement. But when you use supplement, D3 is preferred over D2 because it has longer half-life and it's more effective. So there are some evidence showing D3 is a little bit better than D2, but the difference is the difference between giving D2 and D3 is minimal. In this study, the difference between the two was only 6 nanogram per ml. This might be clinically insignificant. The only time where you prefer D2 over D3 is if the individual is a vegan. So sometimes you might need to give an active vitamin D if the liver problem or kidney problem, rather than giving the provitamin D, you should give the active vitamin D, either calcidiol for liver disease or calcitriol for kidney disease. The other common question I had from patients and my colleagues is, isn't the sun enough to correct vitamin D deficiency, right? So patients will check their vitamin D level routinely at the general checkup in the labs, and they'll come to me, what if I get sunbath rather than a supplement, right? So what does the evidence show? It's contrary to our thinking. Sunlight exposure helps to increase vitamin D, that's for sure, but it's not always enough to replete to normal levels. So for instance, this study, including elderly patients, population in nursing homes, they were randomized to sun-exposed versus supplementation. So sun-exposed individuals, the vitamin D level improved, but only half of the sun-exposed individuals reached sufficient normalized level. So this indicates that sun exposure helps, but does not correct the problem totally. This another Korean study included adults with less than 20 nanogram per ml. So they were randomized to sun exposure, supplement, or routine usual daily living. And in this study, vitamin D supplementation outperformed sunlight exposure. So having sunlight exposure is not enough to correct vitamin D deficiency. The last section is what can we do at public level to prevent. We said vitamin D deficiency is common. We said vitamin D deficiency is associated with bone outcomes. We said vitamin D deficiency is associated with extraskeletal health problems, right? So, and the problem is so common, close to half of the global population affected, right? So we need public health level interventions. So these are the 3 options for public health approaches. One is increasing adequate sunlight exposure, but mind you, sunlight exposure has risks as well. I'll show you that. And the more effective strategy is food fortification, as in milk, flour, oil, and others. And the other is empiric vitamin D supplementation in high-risk groups. Empiric meaning you give vitamin D supplementation for high-risk groups without even knowing their vitamin D level. So sun exposure, what most patients tell me is, I'm afraid of skin cancer, so I would rather take supplement rather than get a sunbath. So that's a real concern, actually. And actually communicating the benefits and risks of sun exposure is confusing the public. The dermatologist will say shy away from the sun, and the endocrinologist will say you should get sunbath, right, for the vitamin D. So this is confusing the public, and I get that. So we know it's a base source of vitamin D, and it has also other health benefits, including improving mood and sleep patterns. But there are real risks, including sunburn, photoaging, and the more worrisome is skin cancer. We know that ultraviolet radiation is a carcinogen, and it can give you, melanoma, squamous cell carcinoma, or basal cell carcinoma of the skin. So the risk is there. So it's difficult to say, get out and get sunbath, right? So the other is dietary fortification. We said that natural food is not enriched in vitamin D, so food fortification is important. These are the daily reference intake advised by the National Academy of Medicine. So for most of the guys, including the attendants of this webinar, we need 600 units of vitamin D per day. It could be from supplement, or it could be from fortification. The other is empiric vitamin D supplementation in high-risk groups. So these are the 4 high-risk groups that the Endocrine Society recommended to supplement empirically. Empirically meaning you don't have to test them to prescribe vitamin D supplementation, right? So one is children, infants and children and adolescents up to 18 years. This is when the bone mass accrues, and we don't want to risk vitamin D and calcium deficiency. So this prevents nutritional rickets. It also is associated with low risk of respiratory tract infection. So you have to supplement these kids. And the second group is the extreme age group is above 75 years. So vitamin D is shown to lower the risk of mortality, all-cause mortality. So empiric vitamin D supplementation is indicated in this age group. Just give them a supplement, even without the need to test. The third group is pregnant mothers. So vitamin D is shown to lower the risk of many perinatal outcomes, including preeclampsia, intrauterine mortality, preterm birth, SJ, and neonatal mortality. So all pregnant mothers should be supplemented. So most of the prenatal vitamins, they have vitamin D in it. Most of them have about 400 units. If you add additional supplements, that will reach about 600. And the other new recommendation is empiric vitamin D supplementation is indicated for individuals with very high risk prediabetes. So vitamin D supplementation is proven to show progression of prediabetes to diabetes. So in this studies, they use about 1,000 units daily recommendation. So when we say empiric supplementation, it doesn't have to be a tablet per se. So it could be fortified foods or supplements combined. But these guidelines have limitations. One, the updated Endocrine Society guidelines do not clearly define the specific. I told you that the Endocrine Society guideline in 2011 has thresholds. Below 30 is insufficiency, below 20 is deficiency, right? The updated Endocrine Society guideline does not use these thresholds anymore because the evidences were not sufficient to say this is deficiency, this is insufficient. And the guideline also do not clearly define high-risk prediabetes. What's high risk, what is the normal risk prediabetes was not clearly defined in this study. And the evidence for extraskeletal health benefits for the pregnancy outcomes, for mortality outcomes, for diabetes prevention outcomes were really modest. So in summary, test and supplement selectively. So the guidelines are shifting away from universal screening and supplementation towards evidence-based selective testing when indicated, and empiric supplementation in very high-risk groups. And accurate testing, reliable testing is crucial when testing is indicated, as in bone disease, unexplained hypocalcemia, malabsorption, CKD, or bone problems. You need to test vitamin D. When you need to test vitamin D, you need a reliable testing. So quality tests is emphasized in all the vitamin D guidelines. So when there's an indication to test for vitamin D, we must have confidence in the results. It's so common in our city to see inter-lab variability. Some of them check it at one lab, they find a number, and they check the next day. It's completely different, right? So we need quality tests, accurate, reliable, and accessible. Lab testing is so important in vitamin D assessment. And that's why the Endocrine Society highlighted the challenge is assay variability, which makes laboratory partners like Wondfo crucial for us to make informed decision. So this is all what I have. These are my contacts for future consultations and discussions. Thank you.
Thank you, Dr. Melaku, for the incredible presentation. And apologies everyone, I was having some network issues earlier, so I couldn't properly introduce our distinguished speaker. I would like to take a moment to highlight Dr. Melaku's remarkable accomplishments. He's an endocrinologist at Tukur Anbessa Hospital and an assistant professor of internal medicine at Addis Ababa University. He has also pursued advanced training in healthcare management at the University of Toronto, in lipidology at the Open Medical Institute in Austria, and in implementation science at Emory University in the US. Beyond his clinical work, he's a passionate advocate and a dedicated medical educator. And we are truly honored to have him with us today. Thank you very much, Dr. Melaku, for that insightful presentation. And I think we all have a clearer picture of the clinical insight and importance of vitamin D. We will now take a few moments for question and answer from the audience. So please drop your questions in the chat box and we'll take 3 or 4 questions from there. Okay, I think we have some questions here.
Review, if you get some, you can say it out loud.
Okay, okay. I think they can't mute their microphone.
What should I do?
So,
okay.
Let me read it out for you, and you can answer the question. So, one question is from Getacho Wenda Fresh. The question is, in our setup, for instance, neurological problems and muscle problems, problems diagnosed with is it diagnosed with vitamin D deficiency? I think that's his question. Or
okay, if I get what he said, so subclinical vitamin deficiency, the clinical presentations are subtle, non-specific, and you can't really localize where the problem is. And if the clinician thinks this could be vitamin D deficiency, you should test. So the aim of today's presentation is to say, don't test, by the way. My message is to test wisely. And when you test, make it count using quality assays like that of the today's partner, right? So in this case, if there was a study by Dr. Gutta some 5 or 6 years back that he assessed the vitamin D status of patients who presented with non-specific musculoskeletal and neuropsychiatric manifestation at one of the private center, and over 60% of them were found to have vitamin D deficiency. And this was an observational study, by the way. It was not an interventional study. Some of the symptoms improved remarkably with supplementation. So this indicates that when you have a clinical suspicion of vitamin deficiency contributing to the symptom, please test. Please test. But do use a reliable assay, because vitamin D measurement is not accurate oftentimes. That's why we are having this discussion. We need reliable lab partners when we decide to do vitamin D testing. But doing vitamin D testing for the general population without indication is not recommended. Yeah.
Okay. So the second question is from Zarihun. He has 2 questions. The first one is oral versus IMA dose. Which one do you prefer? And the second one is, should we supplement all pre-diabetes? Any recommendation on autoimmune diseases?
Excellent. How much to give for empiric supplementation? The guidelines reviewed the evidences on different modes of administration, different doses of vitamin D. So the most convincing finding was giving smaller, consistent doses was better than intermittent mega doses. But these IM mega doses can be used in patients who had malabsorption that we can't fix. So I'm not disregarding the use of parenteral therapy, but the guidelines emphasize the use of low-dose vitamin D on daily basis rather than intermittent mega-dose for vitamin D supplementation. The second, should I supplement vitamin D for prediabetes? So this is where the guideline was weak. So they did not define what high-risk prediabetes is. The indication is use vitamin D supplementation empirically for high-risk prediabetes to prevent progression to diabetes, right? But they could not define high risk. So what I do in clinical practice is I kind of give supplement in addition to lifestyle when a patient with prediabetes had a very high risk of progression, including history of GDM. You know, if a mother has GDM and is now prediabetes, she's high likely to have overt diabetes in few years. And those with obesity over BMI of over 30, these two groups are really very high risk of progression to type 2 diabetes. So I do supplement this kind of two groups of patients, but the guideline does not clearly define what high risk versus low risk prediabetes means. For autoimmune disease, so there were lots of studies on, we know that vitamin D deficiency contributes to autoimmune disease. If you just see the epidemiology, type 1 diabetes is so common in Scandinavian countries when the sunlight exposure is so minimal. But supplementation was not effective in preventing any of the autoimmune disease. That's why we say the association of vitamin D and extraskeletal health is controversial. You know, the causal factor is not established yet. Thank you.
Okay, thank you. So the third question is from Gatu. The question is the appropriate time of the day for sunlight exposure.
Excellent. So the base time, the simplest rule of thumb is if your shadow is shorter than you, that's a good timing, right? If your shadow is longer than you, it means the sun is hitting you very slant, right? So that's not a good vitamin D producing exposure. So that's the simplest rule of thumb. So the best would be between 10 a.m. and 10 a.m. In the morning and 3 p.m. in the afternoon, right? In terms of vitamin D synthesis, but there is a risk. We said there is a risk, right? And this is the worst time to get the risks, including sunburn, photoaging, and skin cancer. So I would advise to get sun exposure, before 11 a.m. in the morning or after 4 p.m. in the afternoon, to balance the risks and the benefits. Otherwise, the best time is when your shadow is shorter than you. But that comes with the highest risk of sunlight-related, ultraviolet-related complications. We have to balance that. So when you read what's the best time when to get sun exposure and what's the worst time to get sun exposure, you get conflicting results because of the factor I just told you.
Okay, so let's take one last question from Dagma with Salomon. For a patient with vitamin D level between 12 to 13, we supplement calcium without testing calcium level. As a routine, is this appropriate in relation to the calcium level resulting in renal stone if it's normal level?
Yes, so for mild to moderate deficiency, so mind you, severe deficiency is defined by vitamin D level below 12 nanogram per ml, and mild to moderate deficiency is defined as between 12 and 20, right? Anything above 20 is normal, according to most of the guidelines. It was the Endocrine Society that defined value between 20 to 30 as insufficiency, but now that is no more endorsed by the Endocrine Society, so I wouldn't worry about vitamin D level above 20. So for those between 12 to 20, you don't need further testing beyond the vitamin D, including calcium, PTH, ALDP, bone marrow assessment, or malabsorption assessment, or anything else. So this is a mild deficiency. You can just supplement with a vitamin D level between 600 to 1,000 units. I don't have any specific brand preference which vitamin to give. So you don't have to check calcium, PTH, or any other further renal function electrolyte for mild to moderate vitamin D deficiency.
Okay. So thank you, Doctor. That will be it for the questions. And thank you, everyone, for the engaging discussion. And I think Dr. Melaku can answer your question, some of your questions on the chat box also. So let's move on to the next part of our webinar. As you know, accurate diagnosis is at the heart of effective patient management, and Wondfo is committed to advancing diagnostics in our healthcare system. In this session, we'll introduce you to our new generation of vitamin D testing solutions designed to deliver fast, reliable, and convenient results. It's my pleasure to introduce Mohammed, our sales engineer at Wondfo Ethiopia. He will share with us the latest advancement in vitamin D testing and how Wondfo's innovative diagnostic solutions are supporting clinicians and improving patient outcomes. So, Mohammed, welcome.
Hello, everyone. Hello.
Yeah, we can hear you. Yeah, we can hear you.
Can you see my screen? Can you see my screen?
Yes.
Okay. Thank you, Mohammed. Hello, everyone. Welcome to Wondfo. This is Mohammed from Wondfo Ethiopia and from regional representative. I'm going to present the new advanced Wondfo vitamin D. On this presentation, I will briefly introduce the company overview, Wondfo Ethiopia, and Wondfo technology, and the main part is our new advanced vitamin D testing. Let me start from Wondfo. We were founded in 1992, so now we have more than 30 years experience in POCT, and we are the leading POCT company in China. We focus on research and development, manufacturing, sales, and service of diagnostic reagent and equipments. And we are the leading POCT manufacturer in China and also in the world. This is a milestone of Wondfo. I will just pick a few key milestones from our bunch milestones. In 2002, Wondfo started the international business. Then in 2009, our subsidiary Wondfo USA was established. In the same year, we passed US FDA on-site audit, the first batch in IVD industry in the world. In 2011, we were granted as the National Regional Cooperative Engineering Lab, and also the first one in China POCT industry, which means we can get subsidiary and financial support from China government. In 2019, our first overseas local manufacturing was started in Mexico, and 2020 first batch got approved by NMPA for COVID-19 antigen and antibody test in China. We were the first company from China. As you know, COVID-19 were started in China, and we were the first company who got the solution for COVID-19. And on 2020, our installation from the worldwide, it was greater extra. We have more than 600 registered certificates and over 400 valid patents. And for IVDR, we are the first one who got registration for CRP and HbA1c market in China. Now we can move to the second part, which is Wondfo Ethiopia. Wondfo Ethiopia is a proud member of Wondfo Biotics and Wondfo Biotics family, global leader in POCT product and services. Wondfo established in Ethiopia on 2012 and registered with Ethiopia Food and Drug Authority, or EFDA, as a medical equipment manufacturer. It's more than 13 years in the Ethiopia market. We have a lot of local collaboration, work with a local supplier to deliver high quality medical equipment to healthcare facility across all over Ethiopia. Let's see our product distribution in Ethiopia. On 2012, on the first year, we awarded IPSA international tender on H. pylori, HBS, HCVs, syphilis, and fecal occult blood, which around 3 million tests we distribute to Ethiopia through IPSA. On immunoassay, we registered our immunoassay and started distributed in 2016. One of our biggest consumers are St. Paul, UNSA, Arsho, Lancet. Now we have more than 2,000 units of actually on only immunoassay unit. We have more than on fine care immunoassay. We have more than 2,000 units. We have also another immunoassay products, which is Malumi and Acryclea. And our top items on immunoassay are HbA1c, CRP, thyroid, vitamin D, including the new vitamin D, a tumor, cardiac markers, and fertility markers. On electrochemistry, we have a coagulation and a blood gas and electrolyte analyzer. We registered and started business on 2020. Our top users are St. Paul, Lancet, MCM, Addis Cardiac Center, and Ethio Istanbul hospitals. On top items, PTA, PTT, ACT, electrolyte, and blood gas, in annual income of more than 200,000 tests per year. On POCT CLIA, which is called ACRE, we registered in 2023 and started business in 2024. Our top end users are Leghar Hospital, American Medical Center, Sanai Medical Center, UNSA, Hiotfana University Hospital, and Dilla University Hospitals are top customers of our POCT CLIA. And the top tests are vitamin D, thyroid, tumor anemia, and extra. And in a year, we install more than 50 units. Now around 75 units installed in Ethiopia on POCT CLIA or ACRE machines. On pathology, we are ongoing on registration, and we are still on process of the installation with Swiss and Onco Diagnostic to do a tumor markers, and soon we will install this product in there. On 2025, we started negotiation with ICMC for our molecular diagnostic products. We will have HPV tests for screening, and also we have HPLC. We will register in 2026, and we already contacted and received order from Sanai, Hiotfana Hospital, and Lancet. So we have 12 importers and 300 local wholesalers in all over the country. Let's come to the technology. Our biggest focus is on POCT, but we look beyond POCT. We have 9 technologies. The first one is immunocolloidal gold platform, which is a rapid test kit, which is positive, negative, or a qualitative one. The second, our biggest technology is immunofluorescence, which is a fine care. Our third technology is electrochemistry platform, which is blood gas and electrolyte with coagulation analyzer. Our fourth technology is chemiluminescence platform, which is ACRE and Smart Lumi. There is a molecular diagnostic platform, HPLC for HbA1c variants, pathological diagnosis, which is like IHC instrument platform, biological raw material platforms. So we have 9 big technologies. As you can see, our product portfolio, immunofluorescence, which is different versions of fine care, coagulation analyzer, we have also different versions, blood gas analyzer, so we have 2 versions, dry chemistry, colloidal cooled. We have more than 20 types of colloidal cooled products, chemiluminescence, molecular and immunohistochemistry. So we have 8 product platforms on portfolio. So let's come to our today's biggest topic, which is advanced vitamin D testing. So already doctors mentioned a lot about vitamin D. So why we do vitamin D tests? The first one is to detect deficiency and assess bone health. So if we catch the problem early before the symptom appear, we can control vitamin D deficiency or vitamin D related problems, because vitamin D is crucial for absorbing calcium and phosphate to build and maintain a strong bone. The other is to guide supplementation. Take the right dose, not too much or not too little, because that does make a poison. So vitamin D testing guide us the proper supplementation to track progresses and also monitor high risk groups like women, elderly, pregnancy, and other chronic disease patients. Let's come to our new vitamin D version. Our technology is fluorescence immunoassay or FIA meter, and the test is a quantitative test. Our fluorescence products are portable, easy to use, and a broad test menu. It's more than 59 items, and we have 3 versions in Ethiopia: FS 113, 114, and 205. Our new version vitamin D is the one-step version, which is sampling, buffering, mixing, and testing. To get the result, it needs only 10 minutes in a small sample volume, which is 15 microliter. And our storage is room temperature, which is 4 to 30, and it supports whole blood. So this is our new vitamin D. On the previous or old vitamin D, there were a lot of consumables like detection buffer, releasing buffer, and also extra times. So this one, there is no detection buffer, no releasing buffer, and no extra incubation time. The previous version, it needs extra incubation time for 10 minutes, but for this one, 10 minutes is for result. So we have 2 versions on the new one, which is type A vitamin D reagent kit and type B vitamin D reagent kits. For type A, it needs a pipette. For type B, doesn't need a micropipette. It's like most of you, I'm hoping like you are using our fine care machines, so you know how to test CRP. For this type B vitamin D reagent kit is just like our CRP reagent. So our reference differentiation is W241, P008 is for type A and P009 is for type B. For our meteorology, is a small molecule sandwich detection technology. We are the first company in the world to achieve a sandwich method technology on FIA products. For the new vitamin D version, all need to check is our machine software version. Old vitamin D version, I mean the old version of fine cares like for fine care 113, 205 and 114 doesn't give a quality product results on the new version of vitamin D. So we need to check our machine software version, which is for 113 is 18.2 version is the latest one. For 114 is version 174 is the latest one, and for FS 205 version 189. So we need to check our machine's software version before doing our new vitamin D test on the laboratory. So the reaction time is 10 minutes, and the quality is very high on CB, less than 10% with Roche and Abbott. Our new vitamin D also supports whole blood, which is amazing on vitamin D testing in POCT methodology. Also, it supports finger stick blood. So we are coming from complexity to simplicity. Our previous vitamin D version was a complicated step, long reaction time, limited sample type, which doesn't support whole blood and finger stick bloods. Our new version vitamin D, it's one step sample and buffer mixing, get result in 10 minutes, support whole blood and finger stick blood sample type, and only 15 microliter sample volume needed. For this one, we already have sampler in the reagent kit for version A and version B. So you can use either of the version of vitamin D of our new version. So what kind of inducers are type A and type B suitable for? For type A, sample type supported venous whole blood, finger stick, serum, and plasma. Actually, both of them use this one. The difference is pipette is necessary for testing for type A vitamin D version, which makes it suitable for professional setting like laboratory, hospital, clinic, and medical centers. It's also support a finger stick blood because it also have a sampler, so it can be used for sampling for kids, infants, which have to take venous blood. For type B vitamin D reagent kit, it can be completed without a pipette, support finger stick blood sampling, so it can be used for sampling for kids and infants, specifically for a pediatric specialty clinics can use this type B1. Our application scenario in endocrinology, wellness management institution, pediatric and child clinics, obstetric and postpartum recovery centers, geriatric and orthopedic clinics are the application scenario for our vitamin D. We have a lot of validations on vitamin D. So the correlation rate between Roche, Eclia vitamin D total 3 and FineCare vitamin D is high, which is 0.9037 range, or CB of 10% for a concentration range. FineCare vitamin D and Avias vitamin D new are compared with Roche together, and FineCare vitamin D is proved to have a better correlation rate with Roche. So these are some of the validation and comparison results done in some other countries. You can see in Pakistan, Myanmar, Jordan, and Azerbaijan. We have also a comparison of vitamin D with SNIB and Abbott. As you can see, the correlation is very nearby and similar results with Abbott and SNIB. So the key benefit and features of our new vitamin D. First one is extremely simple workflow because just only sampling, mixing, and testing. The other is very small sample use because you need only 50 microliter, and high frequency scenario because it need only 10 minutes. Fourth one is monotest design, prevent cross contamination. Multiple sample compatibility, it supports whole blood, finger stick, serum, and plasma, and also instant test result, which is 10 minutes. Get the first result. Why we choose Wondfo? Wondfo credibility is a leading global company in IVD market, recognized for its high quality and innovative point of care testing solutions. With a presence in over 150 countries, WHO pre-qualified products for our HIV tests. It has established a strong international reputations. Wondfo Ethiopia also have a local team, provide a local technical support, training, and services. We ensure a reliable supply and a supply chain and inventory right here in Addis Ababa, and we're dedicated. Customer care is our priority. These are some of our top achievements in Ethiopia. We have a lot of recommendation letters. Let me show you our recommendation letters. So we got a lot of the recommendation letter from our top customers. You can see also they have recommendation letter for use of our products for HbA1c. Our cardiac center. So using our products, now they will going to use our new vitamin D version, because all of our customers. Silk Road hospitals also they are using our products for blood gas in ICU and coagulation in main laboratory. So Wondfo Ethiopia has a lot of achievements. We have also recommendation letter from Nordic Medical Center for use of our products. So they are using our HbA1c, CRP, thyroid, PSA, cardiac markers, and blood gas from 2021. Also, ICMC hospital, they are using our products. These are our recommendation letters. So from 2018, they are using Fine Care for those all tests. So Sunlight Medical Center, it's our biggest customer for Fine Care and Acre products. So here our hospital. So we have a lot of recommendation letters to consume our time. Let's back to our presentation. So we attended a lot of conference, training, and installations. Here you can see on 2022, we participated in conference in Black Lion Hospital, training 2 agents in 2023, training blood gas analyzer in St. Paul in 2024, installation and training in Black Lion Hospital for Diabetes Association, installation in American Medical Center in training agent in 2024. We are also working with different associations as MAWA, you can see in 2022, SEMI conference in 2025, ACM conference in 2024, and also working with Ethiopian Diabetic Association, Hepatology Association, and Ethiopian Medical Association in 2025. Wondfo Ethiopia also have academic exchanges. We invited Tigray and African Union peoples to visit our head office in 2023. Wondfo Ethiopia team also visited Gemma University. Africa Union and UNICEF visited Wondfo headquarters in 2024. Dr. Ahmed from Sami and Dr. Bitan from Ethiopia Diabetes Association visited Wondfo headquarters in 2025. We are also giving a donation to different donations. Actually, in COVID, we donated more than 100. Before the COVID, we donated more than 100 units to Oromia Health Bureau, and also we donated Amhara Health Bureau for Fine-Care 112, Fine-Care 112 in 2022 for destruction of our area. And also we donated COVID-19, 1,000 COVID-19 test kit to Ministry of Health in April 2020. So we are doing our social tasks here. So Wondfo Ethiopia has a lot of NGO cooperation with also coagulation donated to Addis Ababa Cardiac Center or Ethiopia Cardiac Center in 2021. Also blood gas donated to Pink Lotus Breast Cancer Center in 2021. We issued a lot of certificates on our donation and cooperations, and also our achievements in headquarters. As you can see, we have a certificate in our products, EU certificates for IVDR and NHCP certificate for HbA1c, Fine-Care 113 and 205. This is the biggest research center in the world, so we get a lot of certificates. Also, Ethiopia ambassador who visited our headquarters. So this is a wonderful supported COVID-19 Ethiopia. As you can see, our certificate of recognition from Cardiac Center Ethiopia. So Wondfo Ethiopia are doing a lot of amazing things in the market, and also so we are doing also our social responsibility, where we did a free HbA1c test for a mass sport activity organized by Ministry of Health and Addis Ababa City Administration. And also we did HbA1c free tests at Ministry of Health and Ethiopia Diabetes Association event in 2024. On this event, we did more than 400 tests within 3 days for screening of HbA1c and also a follow-up people's. Wondfo footprint in Ethiopia, we achieved a lot of, covered a lot of area. All over Ethiopia, we have products and the customers. Our focus area or our biggest area are Addis Ababa, Hawassa, Adama, Drida, Jijjiga, Harari region, Arba Minch, Walaita, Jemma, Mekelle, Bahar Dar. And also we have cooperation with health bureaus, Addis Ababa Health Bureau, Drida City Health Bureau, Harari region, Oromia, and a lot of health bureau. We have letters from cooperation. Also cooperation with local doctors, association, suppliers, and health facilities. Racing for life is our slogan. This is all about our today's presentation.
Okay. Thank you very much, Mohammed. That was a very practical and informative session. We'll now take a few questions from the attendees. Please, if you have any question, drop it in the chat box and we'll address them one by one. If you have any questions, please. Okay, if there is no questions from the attendees, okay, we'll now move to the next part. Thank you, Mohammed, again. So let's move to the next part of the webinar. Now we would like to take a brief moment to hear from our valued partners at Blue Health Ethiopia. Please join me in welcoming Dr. Hino, a representative from the organization, who will share a few words with us. Dr. Hino.
All right. Thank you very much, Dr. Mati, and also thanks to all the participants for gathering on this webinar. Thank you to Dr. Melaku Taye. It was an insightful presentation, and we hope to see you in future Blue Health seminars with different topics. So, Blue Health Ethiopia is a tribalizing healthcare innovation company dedicated to enhancing emergency response, professional healthcare education, and community health outcomes in Ethiopia. Through our flagship solutions, such as the Darash mobile app and an advanced continuous professional development platform, the Blue Health Ethiopia CPD website, we address critical gaps in emergency care, healthcare training, and medical knowledge dissemination. So today we would love to thank Wondfo Ethiopia in presenting on our platform. And for all the interested participants on Blue Health virtual seminars, you can access our previous medical seminars in our YouTube channel, as well as our Blue Health Ethiopia CPD website, which I will be posting it in the chat box. And for today's seminar, you will be having the quiz right now, and for those of you who score 60% and above, you will be having a free CPD certificate, which is sponsored by Wondfo Ethiopia, and thank you for that. Thank you, Dr. Mati.
Okay. Thank you, Dr. Hino, and thank you, Blue Health Ethiopia, for the collaboration and partnership in making this webinar possible. So as we come to the end of our session, I want to extend my heartfelt thanks to all of you for attending today's webinar, and a very special thank you to our esteemed speaker, Dr. Melaku, for generously sharing your time, expertise, and perspectives with us, and Mohammed for presenting the wonderful diagnostic solutions. Thank you. Vitamin D testing plays a crucial role in connecting clinical knowledge with practical decision making. We hope today's discussion has provided you with valuable insights and tools to enhance patient care in your practice. Thank you once again, and we look forward to seeing you at our future webinars, and we will drop the link to the question from Blue Health Ethiopia for getting the CU point in the chat box. So if you have any further questions regarding our products, vitamin D reagent, or additional support from Wondfo Ethiopia, please feel free to reach out, and we'll also share our email in the chat box for follow-up. Goodbye, everyone, and have a wonderful day. Okay, thank you everyone. That's all for the webinar. Goodbye.